maybe with Pius. Introduce yourself, Pius.
Good day, colleagues. I'm Pius from Eswatini Hospice.
Good morning, colleagues. I'm Palliative from Eswatini Hospice.
Morning, colleagues. I'm Sandile from Eswatini Hospice at home.
Good afternoon, colleagues.
Oh.
I'm saying how is the hospice at home too.
Good day to you, thank you, Tim. Can we have Thandazi Melani introduce yourself? And if there's any other colleagues joining with you, please introduce them as well.
Good afternoon, colleagues.
Afternoon.
It's Thandazi Melani here from Manzini Government Hospital, Palliative Care Department. For now, I'll be joining alone. My colleagues are a bit busy, but I'm hoping they'll be joining a bit later. Thank you.
Thank you, Thandazile. Malaika, please introduce yourself.
Hello everyone, I am Malaika from Echo India and I'm executive in Echo India. Thank you.
Thank you for joining us, Malaika and Thandazile. We are also joined by Babel Kele. Can you kindly introduce yourself?
Afternoon, team. My name is Saveno from Eswatini Hospice.
Thank you, Mr. Ikele. Can we have Mage Zodwa introduce herself?
Good afternoon, colleagues. Thank you for the opportunity. So Takamete, welcome to Eswatini Hospice.
Thank you. Thank you for joining us, Mage. Colleagues, if there's any other, maybe colleagues who will be joining during the session, maybe from one gadget, please also use the chat box for introductions. Just a reminder, colleagues, that we should have our phones on silence, so that we cannot have any interferences during the session, and that we remain muted unless there's something that you want to communicate. So you can always use the chat box for communication during the session, or use the raise of hand, then unmute yourself. So last session, we had Professor W. Akunda from Uganda, who was taking us through advanced conversions and opioid side effects. So for today's session, we'll be having Mr. S. Mashangu from Eswatini Hospice at Home team, who will be taking us through physical treatment approaches for pain management in palliative care. Mr. Mashangu, go ahead.
Thank you so much, colleagues, for your time, and we hope you enjoyed the session. Last week was a great session. We were learning a lot on dealing with people with risk of substance use disorder. So we are in a series, and we are hoping to finish it around October. What we can say, colleagues, is that we continue to join and attend the sessions. And by the end of this batch, we are looking forward to have then batch test. Then we have our attendance certificates for these sessions on pain management. What we can say today, we will be looking at, we will be starting on non-pharmacological management. So the batch that we are in, or this series we are treating, is on pharmacological and non-pharmacological management. So now we are taking the other phase of approaching how to then complement pharmacological means in management of palliative care patients. So today we will be looking at how to use the physical treatment. We are used to this one because most of us here were nurses, and we are hoping RFM, our case presenters, will join us soon because we're looking at their case today. So I will just be providing a summary of what we know currently on physical treatment. We may have many, but we will discuss very few for today. And then we will then have a discussion, and then we will also look around on, I want to put my screen on presentation mode. Yes. So then we will also be able to look at that. One thing I will need to also understand is that one of the principles of symptom management emphasizes that we used to always start with the non-pharmacological means before we jump to the medical ones. So in our previous sessions since October last year, we have been looking around pain assessment, we've been looking around pain management, we've been looking around the principles around opioids and analgesics. We have been looking around side effects. We've been looking around moving up and down or converting from one opioid to the next. So we've been covering around the pharmacology management of pain. But today we are starting on the non-pharmacological. So I will say that for comprehensive pain treatment, we should also include the non-pharmacological treatment options. So there are many. And the chronic pain experience is multidimensional, so treatment should be also multidimensional. When we talk of chronic pain, it's not just one side, so it comes in different spheres for the patient. We mentioned those areas that the patient can come in four aspects. It could be physical, social, psychological, and spiritual. So for effective management of this multidimensional aspect, so we need to be also using multidimensional activities or approaches. So then there comes non-pharmacological options. So why are we talking about the emphasis on palliative care and the use of non-pharmacological measures, especially including this physical treatment, is that there is an evidence, research is showing to us that the use of physical treatment approaches, including mind and body approaches, which we will cover maybe in our next session, is very important for patients and must be individualized for preference and effectiveness. So what does that mean? It means that when it's used very well, it must be an individualized activity and must be provided for the effectiveness or to be evaluated if it's effective for that individual person. There's no one shoe fits all when it comes to physical approaches. So there are many. You may have a long list than that what I've presented already here, which is called therapy. We are aware of it, and the exercise and activity, we know it. Heat therapy, we know it, immobilization. We are used to these therapies, manual therapy with positioning and pressure, these are the most common ones to be used. And then we also have the spinal manipulation, mobilization therapy, transcutaneous, inferential electrical nerve stimulation, they call TENS. So this one that they need specialties. Then we also have vibrations, So we have many, we may list them. There are many, but we'll focus on a few today. That we sometimes need to be very cautious of them when we are using them. These maybe we'll look around the cold therapy. We know this. So we use it to constrict the blood vessels, especially cold therapy, with the purpose of decreasing the circulation and decreasing pain by numbing the affected area. So that's why we are applying heat. So, and it reduces the painful muscle spasms. So when a patient presents with muscle spasms and has an inflammation or has a desire to scratch or has an itchiness, so sometimes applying cold will reduce that desire to scratch. And it decreases the sensation of pain within the applied area. So this one is very good for localized pain. If the pain is somatic and it's localized, so you are able to say, this is where the pain is, other than visceral pain where you cannot localize where is exactly it. So especially for somatic pain, this one is very good. But also for neuropathic pain, it works depending on when that area with the neuropathy is. When then it's a referred pain, it will be difficult. But when you know where it's coming from, you will find that we are able then to use the cold therapy thing. So cold applications are used more for reducing the swelling following an immediate acute injury or numbing myofascial pain, but are very helpful in several chronic pain conditions when it is alternated with heat application. So we know that myofascial pain is the one that has to do with muscles. So we use this one. So it's very good when it comes to somatic pain. So cold therapy and heat therapy works very well for those ones. And then it is applied using frozen jelly packs. You know, they are there in our fridges in the facilities, or use ice packs, you use a cold cloth, you use ice cube, you don't know, but we use everything. Sometimes it's not encouraged to put directly the ice on the skin. Sometimes people even use frozen packages of vegetables. I want to use this one on my son. So I needed to alleviate the heat. So you get frozen packages of vegetables. So they get those vegetables that are frozen, then they put on the patient to calm that pain. So all these possible applications can conform to body better than a frozen block of ice, but ultimately the person experiencing pain can make the decision. All what we are saying is, all this non-pharmacological, the person who makes the decision is the one who is experiencing the pain, and is the one that will tell you which form of cold therapy is working very well for him. But these are the things we need to understand, that contraindications for cold therapy. One is that when the person is, or that area you want to put the ice is treated by radiation therapy, it is not recommended, because radiation makes the skin to be more sensitive and vulnerable to any external thing. So you find that even you find that they are saying post radiation, you are not supposed to use soap, just use water, don't rub the skin. It's a sensitive skin. So we are not recommended to put cold there, because it will affect the skin very much. A wound in the healing phase also, it has these epithelial cells that are growing there. We are also saying in a healing wound, especially the one that is a granular phase, it's a beefy space or it's a little bit pinkish, don't apply cold there, because we want that circulation to feed those growing epithelial cells. So we don't want them to die because of cold. So we need to not to put cold therapy to those wounds. So also in areas of poor circulation, if there's poor circulation, don't put cold patches there, because what is going to happen, the vessels will constrict, and then that area will be then not perfused very well. So we also have exercise. This one we know very well, exercising. Without clinically significant contraindication, each person reporting chronic pain should be encouraged to engage in some form of routine activity. That's why we are saying patient must be encouraged to do whatever they can do as possible as they can do. Even in palliative care, we encourage them to do activity until they die. Why? It's because this on its own is very important. It's therapeutic even for the patient. So we encourage them to do something. This will also be determined by the prognosis and the functionality status of the patient. So we need to also understand what is happening with the patient. Will this be applicable? Now, no treatment plan is complete without addressing one or more of the following issues. One is the range of motion exercise. We encourage them, even our caregivers, we encourage them, you cannot provide physiotherapy as a specialist, but you can do range of motion exercises. But for the body to have enough circulation and muscles to move for metabolism, you see, we encourage them to do stretching, because we don't want muscle contractures there. So we need them to gain strength through the training, and also for cardiovascular conditioning, for circulation, we want the blood to flow. So we have to encourage them to do exercises. Activity that includes a daily exercise regime is enthusiastically recommended as part of the overall treatment for chronic pain. So there must be something that the patient must do daily. So you must give them some tasks to complete so they can do something. Those things that are the patient can do, then we encourage them to do them. And that one is very recommended. So you give them something to do. And participation activities at any level Any amount and any type is sometimes it is something the person can do to contribute towards wellness. So everybody, depending on the level of functionality, there's something you can do so you can obtain your wellness. So there's no chemical or pharmacological or mechanical substitute for the benefits of activity. So always, even if a patient is on a wheelchair, let's see what activity that person can do. It eliminates or it reduces pain control. As activity promotes functionality, as I've said, it's flexibility, strength, endurance, range of motion, and positive mood. So sometimes it helps psychologically. Inactivity is well known to be detrimental and is leading to muscle atrophy, declining function, negative effect, and a decreased quality of life. So once a person is not active, we say that person is going down in terms of quality of life, even the functionality level. That's why a live human being cannot spend the whole half of a day asleep. There is no way. So he has to be doing something because that one will increase the quality of life. So, but remember, quality of life is defined by the patient. So even here, you will find that when they are active doing things, they begin to define themselves in a different way. But there's another thing that we need to do when it comes to activities, to educate the person experiencing the chronic pain, as well as their families and friends, so that they should emphasize the ongoing of the importance of ongoing activity, so that the relatives are left behind and they are doing and encouraging the patient. And then we also have heat therapy. Heat therapy comes into two forms. We have dry heat and moist heat. So dry heat, its application includes the use of heating pads, hot water bottles, heat lamps, or warm fabric pouches filled with rice or other grains applied directly to the affected area. So that's what we call heat therapy. And also we have the moist heat therapy, which then we say is the application that includes use of warm baths or heated washcloths. So you see, it depends which one you are going to use for your patient. But remember that this one is normally used to dilate the vessels and stimulate circulation, bringing oxygen supply to the patient and other nutrients to the cells. So it's there. It helps in relieving pain, but also it helps in promoting circulation and perfusions of the cells. So you'll find that then oxygenation supplies to the body is doing very well. So we have to do that to provide heat therapy for those patients. However, there is always a danger of sustaining thermal injury if too much heat is applied for too long. Education should emphasize on reducing the risk. So you must assess if this level amount of heat will be able to be carried by the skin, because we're applying this heat, which must be a stress to the skin. So we need not cause some risk. We don't want people to be burnt. And you find people bashing it in your and stand like them. Do not apply heat to an area that is bleeding. We don't do that. The reason is why, when there's bleeding, we want to constrict the vessels. So we need to promote coagulation. So if there's a heat, then circulation is faster and the dilation is there of the vessels. You will find that coagulation will not happen. And also in areas treated with radiation too, we don't put heat therapy because of those issues I've mentioned before. The sensitivity of the skin there. Any acute injury within the first 24 hours, you don't put heat, because we want the body to put platelets. They want the body to constrict that vessel on that area to promote healing. And any area with decreased sensation, I think you can understand why don't you put heat therapy when a person has decreased sensation, especially people with a stroke, who have suffered hemiplegic stroke, or who are those with not functional limbs, who cannot detect any heat somewhere. So those patients, we are saying, don't apply heat therapy with them, because they will not tell you if it's hot or not. You will see blisters coming up and you will be surprised. How come? Because I was helping this patient. And remember, all these therapies are subjective to the patient. So it's the patient that says, is it working for you or is not working? Also, we have what we call vibration, and it's a form of electric massage. You know, some people, they like it. They go for to get it somewhere, spa area, so they get those electric massage units to soothe in pain on skin. and ease knotted muscles. So they go there and provide them. So sometimes if your patients have competent caregivers at home, you can encourage them to try it. Or if they afford to go for those spa areas to get those massage and get these electrical vibrations. So some they will appreciate that. And it will be soothing to them psychologically, and it will help them physically. So we can try to use this physical help. And remember that non-pharmacological measures, they have the same effect as the pharmacological ones. You'll discover that some of the people, they don't need that much panad. They just needed some massage. They just needed some vibrations on the muscles. Then the stress is gone, and the muscle cramps are gone. So vibration seems to be particularly helpful for tight, painful muscles along the cervical or thoracic and lumbar spine areas. So it's very good when it's working around those areas, the spinal areas, the neck, even around the chest. So those areas, you find that this massage, even massage sometimes is good when they are doing it there. So where there are these muscles, so when they are doing these vibrations, they work very well. However, there are contraindications even for vibrations where you do not apply vibration to areas treated with radiation too. Why radiation? Because radiation is a sensitive skin, so we don't want to irritate it, because once it's irritated, it may lead to complications. So we don't want our patient to suffer complications. Even to open wounds, you cannot do that. For the sake of the same reason I mentioned before, the sensitive area of that wound. And an area with a tumor or bony metastasis, it's very fragile, those areas, so you cannot put vibrations there. And do not apply to an extremity that could possibly have a blood clot. You don't do that. Even if they are doing massage, they are cautious of areas with blood clots because they don't want them to split that clot into smaller pieces. They need to go and clog their heart. So we need to be very cautious. I'm just selecting these few because they are the most easily to be used. But otherwise, what we are trying to say today is that while we are using our morphine, we are using our tramadol, we are using all these conventions, let's not put a blind eye to also this one type of non-pharmacology, which is physical therapy. Actually, this one can do wonders for a patient. But remember, it has to be based on what are the preferences of the patient. So comprehensive pain management approach should include a variety of non-pharmacological treatment options. So we need to explore these options together with the patient. Which one will work best for the patient? So as your healthcare worker, our duty is to educate our patients, give them the options where to choose. Then it's the responsibility of the patient to make the choices. So we don't have to force them what to do, but we have to give them the options, give them the pros and cons of every activity that they have to do, and the responsibilities for each choice they have to take. So non-pharmacological intervention can have similar effects as pharmacological intervention. So please, let's remember, actually, if we can, as possible, remember that the main one of the principles of symptom is to use the non-pharmacological interventions before thinking of pharmacological intervention, even in pain management. Let's first explore the non-pharmacological ones. So I think there is nothing new. It was supposed to be a non-pharmacological. So should always be individualized and be patient preferences. Always when we are trying to do this, individualize them and always be patient preferences. I think in our next session, when we are looking then around the mind and body approaches, then when you combine them with physical one, you'll discover that patients sometimes they don't need the pharmacology ones. They need just the non-pharmacology measures, and they are cheap because once you have taught them how to do it, or they've got a good specialist for them, they are able to use them even at home, and it works best for them. So let's manipulate these interventions, and then we opt for the pharmacological ones. Maybe I will end here for today's presentations and say these are the things maybe I can say we can remember. You can also read this from our palliative care guidelines 2018 in the country. We have them. You can go to the American Chronic Pain Association online. You can read about this one. So there are many sources outside there. So I think maybe when we are exploring them, then non-pharmacologicals will be able to in these non-pharmacological measures to use. Especially today, we're covering the physical ones. Thank you so much.
Thank you, Mr. Masango, for the presentation. If we have any questions or comments on Mr. Masango's presentations, can you kindly maybe use the raise of hand, or feel free to use the chat box for any questions or comments on the presentation. Colleagues, use the raise of hand or the chat box. The presentation for me was quite enlightening because I was able to maybe learn a thing or two, especially about cold and heat therapy, that we need to be cautious in order to avoid burns, and that we need to avoid maybe direct application on wounds or on areas exposed to radiation. And also that the exercise and activity physical treatment should be suitable and subjective to the client's maybe needs and medical condition. I don't know if we have any comments. Okay. In the absence of questions or comments, colleagues, I think we can move on to our case presentation for the day. But if there's anyone that still has a question or anything, feel free to use the chat box. We will get back to the issue that you are raising. We are glad that the RFM team has been able to join us. So we would like to ask Nonsigelelo Ntuli to give us today's case presentation. We will be sharing from our screen. Nonsigelelo, are you ready for the presentation? Nonsigelelo, are you able to get us?
Hello, yes, for now.
Okay. You can go ahead with the presentation. We have already shared from our side.
Oh, okay. Afternoon, colleagues. My name is Nonsigelelo, RFM Hospital Palliative Care Nurse. I'll be presenting a case of a 68 years old male, a follow-up diagnosis, left parotid cancer. A problem, patient reports severe sharp pain on left cheek. He sometimes have headache and insomnia. Concern, we are concerned that the patient complains of pill burden and feels like he needs a distraction from his pain or something he can do to relieve his pain without taking medication. Chief complaint, patient complain of headache, insomnia, severe pain on left cheek. Pain score is 8/10. Significant medical surgical history. Patient is a known ART patient on treatment since 2013. He developed a painless small mass, approximately 2 centimeters wide on left cheek, January 2022. The mass increased in size. He went to Mbabane government for consultation and they took a biopsy specimen for histology. 29 July 2022, before results were out, patient came to RFM Hospital to be enrolled on palliative care since RFM Hospital is closer to his home. He presented with a fist-sized lump on left cheek. Lump was having 3 nodes. One of the 3 nodes had already bursted to form a hollow wound with a slab and septic. He complained of occasional mild, moderate pain, but physical, mental, and clinically stable. He was given antibiotics and started dressing with active soap alternatively after cleaning with salty water. He was also given codeine, paracetamol, and bisacodyl to manage his pain. Patient has a wish of removing the mass, but doctors needed to see biopsy results first before they sent patient to operating room. RFM Hospital Palliative Care made a follow-up on results of the biopsy done in Mbabane, and results were found and stated that there is no malignancy. Patient then repeated the results via surgical OPD, when then the surgeon ordered client to do biopsy sampling and histology. Patient did biopsy 26 September 2022, and specimen was taken to Mbabane for histology and waited for results while dressing and taking medication. 25 October 2022, biopsy results came back and revealed that client have metastatic carcinoma. RFM hospital surgeon referred client back to Mbabane to be seen by an oncologist for further management. The oncologist recommended client to do CT scan. Patient has done CT scan, did CT scan. He started chemotherapy January 2023 at Manzini Hospital. He continued doing dressing, refilling his art and pain medication at RFM. He was changed from codeine to morphine syrup for pain since his pain had increased from moderate to severe. Okay, medications. Patient was on codeine 30 milligrams PO 3 times a day, bisacodyl 10 milligrams orally 2 times a day, cloxacillin for the wound 500 milligrams PO 4 times a day, and paracetamol for breakthrough pain 1 gram orally 3 times a day. He was then changed from codeine to morphine 5 milligrams syrup orally 6 hourly, bisacodyl 10 milligrams orally once a day. He is on ART. He's taking TLD. He is also taking amitriptyline 25 milligrams orally, Nocte-brufen 400 milligrams orally 3 times a day, paracetamol 1 gram orally 3 times a day, clotrimoxazole 960 milligrams orally once a day, and metoclopramide. Social history, work status, the patient is ambulating, occupation is a pensioner, education, tertiary education, socioeconomic class is a middle class, marital status widowed, lifestyle habits, smoking and drinking alcohol, relevant health conditions in the close family. His sister died of cervical cancer. Advanced directives. Not yet, the DNI order is not yet discussed. Living will not yet discussed. Advanced decision to refuse treatment not yet discussed. Health care proxy is his son. Mental capacity assessed, yes. Comment if further plan of care will be discussed with his son and other family members. Review of system. Temperature it's 35 degrees Celsius, BP it's 106/76 millimeters of mercury, pulse it's 104 beats per minute, 16 respirations is 16 breaths per minute, oxygen saturation is 98%, pain score it's 8/10. ECOG functionality score it's 2. The symptoms, pain it's severe, there is no dyspnea. Client is a bit anxious sometimes because of insomnia. There is irritability, some mild irritability, but no depression. Sometimes feeling drowsy, especially when he comes back from doing chemotherapy. Sometimes he reports nausea when he is from chemotherapy, when he has come for dressings. And also mild anorexia and the constipation. He also complained of muscle aches whenever he's from doing chemotherapy. Focused investigation, histology was done and patient was found to be having a metastatic carcinoma and then referred to Manzini clinic to refer to Mbabane first. Then they did the further assessment. Then he went to Manzini Hospital to resume chemotherapy. Further plan, patient is adherent to chemotherapy with mild to moderate side effects seen. He reports them and they are well managed. Wound dressing on left cheek is done at RFM Hospital. Wound is decreasing in size, non-septic, red and healing. For distraction, patient was advised to read novels, which he borrows them from the social welfare office. It sometimes goes out to have a chat with friends. He uses her pain medication or his post-chemotherapy drugs whenever there is a great need. He was also advised on how to take his medication without feeling burdened. Thank you.
Thank you, Nonsigelelo, for the case presentation. I believe it was clear for everyone, colleagues. Are there any questions that we have for the RFM team? Any questions or any recommendations based on the case presentation?
Interesting.
Kindly use the chat box or the raise of hand for questions or comments.
Ooh, Suzanne.
There's a hand from Pius.
Thank you very much, Julie, for presentation. Indeed, it's informative. Maybe one would recommend that you may advise the client to modify his lifestyle, probably forfeiting smoking and alcohol, as we know that it may exacerbate the condition of the client. Also, with the analgesics, maybe one if they eliminate one between the ibuprofen and paracetamol. Thank you.
Thank you, Pius, for those recommendations. I'm not sure if Nonsigelelo got them.
Yes, I did got them. Did get them.
Okay, thank you. Thank you, Nantsikelelo. Do we have any other questions or comments or recommendations, colleagues? Okay, Mr. Matang wants to say something on the case.
Okay, thank you so much, colleagues, and thank you so much, RFM, from the great work you have done for this patient. And thank you so much to take the matter and be responsible in ensuring the patient access the care he needs. And we are hoping that now the wound is healing. Also, he will be responding very well to the chemo. And we don't know if metastatic it will be held. We don't know. The prognosis after the treatment, how it will look like. But I have this that I noted from the case, and it's so interesting, Tim. It's the history of the events. You know, this is a pensioner, somebody who's at home and is a widowed person, and then this is the journey this patient has gone through. Last year, it started as a small mass and a biopsy taken. And then, but the patient couldn't stay because something was troubling the patient. So the patient has a lot of trouble. We don't know what was frustrating the patient, but we can assume the nodules or the tumors he was seeing. And then in July last year, before even the results could come up, we then went to RFM feeling not cared for, with one not busted already. So one of the tumor already is busted already. And you can think of the situation the man was going through. And already now he's experiencing a mild to moderate pain. And then the patient, which by that time, also it catched my eye that by that time the patient was already wishing the mask could be removed from him. But then with that desire or wish, and then he was told that no, before we take you to operation room, we will need to take another biopsy while we are still waiting for that one. Need a biopsy so we can know what is it that you have. And then the biopsy taken and stated that there was no malignancy. And this is around July. You know, if you are told that, oh, okay, this is not a malignancy, so it is not cancer, you feel relieved even if you have seen people with cancer. But what puzzled me was that 2 months later, the surgeon then ordered the patient to redo another biopsy. Sampling was done, and then we continued with the wound management. On the next month, I like the quickness of the team, like it's a 30-day move. The biopsy results came back and then revealed that now you have metastatic carcinoma. You know, this alone tells you the pain and trauma this man is going through. It's like in September or in July, I was told I don't have cancer. But 3 months later, you are telling me I have cancer, and this cancer is metastatic. I think that's one of the issues that we might need to go through. I don't know if I even had the opportunity to go through with the patient in that area. This is a man and a retired man now, but he moved to scan with oncology, and then started chemo January. So now he has started, now he has 4 months or so, he has started the chemo, and we are so great he has finally achieved and get that. By the time the patient then later has been changed from codeine to morphine syrup for pain, since the pain have increased. From this, I can tell that psychologically, I think RFM is doing justice in terms of psychological care and emotional care for this man. And the fact that this person is a widow. I don't know if you have got who is the supporter of this person, who is the caregiver, who is there as the shoulder to cry on for this person. I think we need to ascertain that person. Another thing is how has this diagnosis of metastatic cancer has affected the patient and the family. Now that we have lost a sister with a history of cancer in the house, we don't know how is their experience with the cancer that take the life of their sister. And now we have a cancer that might take our father. We don't know what is happening. And now we are going through this chemo. I think also they will need this psychological care in terms of how are they journeying with the chemo, looking at the side effects, the down and up moods, you see. I think also that one should be taken into consideration in terms of the woundedness. I'm happy that the wound is managed very well with antibiotics, also taken care of, it's clean and it's now showing signs of healing. But I think we need now to go deeper to the woundedness of this man, also to take care of that one. Then also the man is complaining of severe pain. I think it's an issue around the morphine prescription. The morphine is the golden standard of pain control. But what we saw is that the physician has so far prescribed morphine to be QID, which is 6 hourly. I don't know the indication. If then it was the issues of kidney function and liver function, maybe that will be beneficial, but we will need something to take care of the 2 hours. Because in the country, I'm not sure we have hydromorphone yet. But then in the absence of hydromorphine, I think we need to consider reducing the interval of morphine, because we might be experiencing this severe pain due to morphine dose failures, because the immediate release works for 4 hours. After 4 hours, it's finished in the blood, it's out, and the pain is up there. And the principle of pain management mentioned that it is very difficult to control an ever-existing pain. So the goal is to keep it low as possible as you can, so that we can have a score less than 5 and down. But if you have 5 score consistently there, I think we need to consider reducing the frequency of the dose of morphine to at least 4 hours other than 6, unless there are other contraindications that are there that requires us to reduce the morphine downward. So I think that one needs to be done, especially for this patient, because the 6 hours is a little bit longer for the patient to control the pain. So may I say, as a palliative care nurse, then advocate for the doctor to reduce the interval to at least 4 hourly. Then we encourage the patient to also take what we call breakthrough pain doses, or even if we need to find out when is the 8 score heated, when is the pain more severe. If the pain is more severe at night, we can encourage the patient to take a double dose, because then he will sleep. But then if it's during the day, we need to find out. Maybe it's during the eating time, then we will need to consider managing what we call incidence pain. So we'll need to give another certain dose of pain before the eating activity, so that the patient may not experience. The goal must be that we reduce the pain from 8 to at least 5. Then we know when it's moderate, now it's a little bit managed pain. So I will say this time around, advocate for the reduce of the interval of morphine to at least 4 hours. Because even it's 4, sometimes other patients will not make it to 4 hours. Then that's why we will call that one dose failure. But this, for now, the patient is given for 4 hours and sold out to pain for 2 hours. Then we are not going to achieve our goal, because we manage the pain for 4 hours But then for 2 hours waiting for the next dose, we are not giving anything. So I will recommend we give it 4 hourly for that, unless there are contraindications, like I said, liver function is not good, or the kidneys are not working well. But if all those function tests are showing the patient is doing very well in terms of clearance and metabolism, may we reduce the dosage to at least 4 hours. I saw there that there was amitriptyline added. I think it was the insomnia. But I would say that we can add the adjuvants if then we are giving the morphine up to the required frequency. Then now we can tell that no, the morphine that we are giving with the titration is not working very well. Can we continue give the amitriptyline just to give the patient a sleep? And it's not a drug we can give for a long time. So for that, for those days while we are still stabilizing our dose for the opioid, we can try. But then, because morphine doesn't have a ceiling, we can titrate. The patient is already at 5 milligrams. But then, what about titrating it? What if it's the lowest dose? Unfortunately, I don't know how long the patient has been on this morphine, because the first 30 days or 14 days, you are aware to trace if the patient is taking the sufficient dose of morphine to alleviate the pain. But I think with the morphine, you can do better with this pain management, and the patient maybe will achieve then the insomnia thing. Then I saw there in the drug, I saw ibuprofen, I saw paracetamol, you know. I understand maybe the ibuprofen is for inflammation and the bones, but then maybe we can eliminate the paracetamol, be left with the ibuprofen. Unfortunately, due to the age of this man, the NSAID ibuprofen will not be okay in the long run for the patient. So I will recommend, if then the ibuprofen is provided as a baseline dose to help with the bone pain on the parotid, I would recommend that we consider looking around alternatives, maybe go towards diclo, and then monitor for gastric ulcers there. If the patient is at risk of developing them, then we put anti-acid drugs there, especially omeprazole there, to prevent the patient develop ulcers. But I would say we will need to evaluate that one too, because ibuprofen sometimes to the elderly quickly moves them to kidney problems. So we need to look around that dose for them. But I think it's an issue of advising the prescribing officer to evaluate the age of the patient and the NSAID provided and the dosages. Maybe you will need a 200 milligram of it other than the 400. So I think you need to evaluate that. But the key dose or pain control drug should be the morphine, and should be titrated as possible as we can while we are monitoring the patient and providing even those breakthrough pains and educating them how best they can take it. There is no way in palliative care we will give medication as PRN. No, we cannot do that, because once you say PRN, the question is, this is a man. When you say PRN, you are saying the man to give when he feels pain. You know, the interpretation of pain is cultural sometimes, you know, and we know Amaswati sometimes they don't like to be seen in pain. So this man will wait until it's 8, then he will take the drug. We will find that it's not working. So I will advise that we give them using the principles of pain management, which will be by the clock. We need to give them by the clock. Tell them how many hours should they take it for hourly, and they should be taken by mouth and by patient and the other things we need to adhere to. But I would say the principle of by the clock will work very well for us in pain relief. We will then be able to know if there are side effects to control, if the patient is tolerating the drugs very well, and then if there are need for titrations, we will be able to know. And then also, I'm happy that the patient has opted for reading books. That's very nice, to keep some time busy. I also think you can also build your strength on building on his spirituality. You know, if he's a Christian and he likes worship, he likes music, those things, they will form distractions. And I'm happy that you have also found the friends who are supporting the patient. I'm not sure with the smoking, if he's still a smoker or not. But if then he is not smoking or he is still smoking, you need to sit down and discuss with the patient on the issue of smoking, because sometimes you will say they must stop and then you will be enemy. Sometimes you say they stop, yet it's what they found pleasure on, and that's what helps them to cope with daily. So these are the issues we need to sit down with the patient and discuss with them in terms of how best the patient can be helped. Because I saw that the patient is mentally stable, and it means the patient can make good decisions. And in terms of the patient and the sons, what can be their roles? I'm happy still to meet them in terms of what could be their role in helping this man. So that would be my contribution, because that's what I saw in your management. So I think we'll work around those issues in terms of that. Even with the nausea and vomiting, sometimes you will find that when they are post chemo, they will have those episodes of nausea and vomiting, but it doesn't last very long because it's just side effect of the chemo. So we can encourage them to go for non-pharmacological interventions. We have people like Tetwa here who are dietitians. I hope you also have people in your facility who can advise the patient in terms of diets to take to cave other drugs that are there in your supply. So I think that also we need to look around in our non-pharmacological ways. Otherwise, I think that's what we need to do. Other than to say PRN for the pain medication, I would say PRN should be like the metoclopramide, like the amitriptyline, you see. But for Brufen, due to the age, I would say we need to look at how long will the person be on ibuprofen, and what will be the indication for ibuprofen. If it's for the bone, then how far is the morphine there? If the morphine is not there, let's look around the dosage. Then cut the brufen at least to 200 and use it as a base for the bone. I think it will work there for the patient. Yeah, I think the issues of anxiety, need to look around the issues of what could be the leading problem of the anxiety. You will find that there are fears that the patient has. Maybe it's rejection by the children, maybe it's death itself. There are many things that can make the patient to be in anxiety. So we need not to ignore it that way. I think the psychologists there or and the social workers will have the time with the patient, allowing the patient to debrief. I think also to see how has the husband coped with the death of the spouse or the wife. I think that one needs to be ascertained, because that one will determine how the husband will deal with that issues and how will he want to deal with his own issues, and even the children in your plan, looking ahead. I think also consulting with the oncologist in terms of how is the patient reacting to the treatment according to his or her assessment. The oncologist will advise you to say, okay, we think we're gonna be able to eradicate the cancer from this patient. Oh no, it has metastasized to the bones, to the head. Where has it metastasized to? And what is the possibility to cure it? If there's no possibility, so those goals could be discussed. If then RFM feels like the goal of the chemo, you cannot discuss it, I can advise, maybe suggest that you can then refer the family to Manzini Hospital, so they discuss the goals of the chemo in terms of its prognosis and stuff going forward, so that they should not lift their hopes high or lower them down. They should understand, because you might find that they understand the cancer and chemo due to their aunt or the sister of the husband. So they might understand how chemo works and what are the problems. We don't know the experience they've had. I think those issues, discussing those issues, will heal them psychologically, and sometimes it will heal them spiritually. They will find something of value on what to do on that. That will be my inputs to this. Otherwise, it's a great job. Looking at the journey the patient is going through, it has been a great move. And I'm happy that you quickly intervened and you help the patient, you linked the patient very well. I think that's one of the things makes the patient to come to you, because he has gained the trust on you. I will end here.
Thank you, Mr. Masao, for the insightful feedback and recommendations. I believe we can all learn a lot from how the RFM team has been able to manage the client. I don't know if there's anything that Nonzile Lolo wants to say before we end the session.
Nothing. For the comments and the recommendations. They are well noted.
Okay. Thank you, Nonzile Lolo and Arakan team for the case presentation. I think we have come to the end of our session, colleagues, unless I'm leaving anyone out. Maybe anyone that has a question or a comment on the case. Whilst waiting on that, can we kindly click on the feedback link in our chat box to give feedback on today's session? I hope I'm not leaving anyone behind, please. Kindly click on the feedback link. So thank you for joining us in today's session. I hope that we're all able to learn a lot from the case presentation to the didactic session we had from Ashamu and Nonzile Lolo. If maybe I saw a few colleagues joining us late during the course of the session. If maybe you feel like you were left out or you missed out on certain things, we do have a YouTube channel where you can be able to maybe access the videos, and also on the IECO platform you can also access the presentations there. So our next session will be on the 24th of May, where we will be looking at mind-body treatment approaches for managing pain in palliative care. So please invite other colleagues for that session, and please join even for that session. Thank you so much, colleagues. This is the end of our session. Have a lovely day.
Thank you, everyone. Let's meet on the 24th. Bye-bye, everyone. See you on the 24th. Thank you for attending today and contributing.
Bye-bye. Thank you.